Hello, a very warm good afternoon to everyone. Continuing with our educative webinar series, today we have a topic which is of increasing importance regarding mycology or fungal infections. So fungi are generally, cause infections as simple as a skin rash to life-threatening infections. And in the COVID pandemic, we have seen outbreaks of mucormycosis, uh, complicating the already complicated scenario. So now, without much ado, over to Dr. Bushra, who will be presenting an overview of mycology.
Good afternoon, everyone. Myself, Dr. Bushra. We'll start the session. Can you able to see the slides? Can you able to see my screen?
Yes.
Okay. So now we'll today my topic is about overview of mycology, which is the fungi, which is an emerging threat. So these are all the four in the four broad headings we'll be discussing our topic today. So coming to introduction, the diagnosis of the mycotic infections is properly dependent upon the proper selection, collection, and even the transport of the appropriate clinical specimen. An active ongoing interaction among the clinician, microbiologist, and pathologist usually conclude the interpretation of the culture and histopathological results. It is very important that the laboratory receives the correct type of the specimen with adequate clinical data to enable it to carry out the proper investigations. So when to suspect and fungal infections. So these infections are significant to health problem, mostly in the immunocompromised patients. The clinical picture varies and can range from colonization to an active infection. So hence it is difficult to diagnose. So suspect fungus when the patient is having prolonged fever, not responding to antibiotic, and the patient who is on prolonged hospitalization, and the patient who is neutropenic, and patient of hematological malignancies, solid organ transplant, DKA, and HIV patients. And the patient who is on prolonged use of steroid also, like more than 3 weeks, will be having the fungal infections. And the patients with the persistent cough, vomiting, and altered sensorium with no obvious diagnosis, hence has to be ruled out with the fungal infection. So coming to the specimen collection in the fungal in the study of mycology, we are having all the type of specimens can be suspected having a fungus. So the types of the fungal samples are we receive cerebrospinal fluid, like we collect in case of the cryptococcal meningitis, and all the X-ray specimens such as pus, aspirated body fluid, CAPD fluid. And among the respiratory fluids, we'll be having sputum, induced sputum, bronchial washings, bronchoalveolar lavage, tracheal secretions, and bone marrow aspirate. So in case of the bone marrow aspirate, to yield fungal growth, the sample is better to be inoculated direct on the SDA media. Skin, hair, and nail samples will receive for the dermatophytic infections, and the swabs. In case of swabs, they are usually recommended if you suspect any kind of otomycosis cases, and if you're suspecting any kind of mucormycosis, the patient is having any kind of black lesion in his mouth. So where you can't biopsy the specimen, you can collect the swabs. Like more than 3 to 4 swabs are usually recommended, better than one swab. Okay, tissue biopsy can be sent and blood sample can be sent for the fungal infections. So what are the doses to be taken out while collecting the specimen for fungus? The specimen volume must be adequate to perform all the tests required. In case of any inadequate material, you can at least, I told, like 2 swabs from a lesion are to be sent, one for the microscopy and the culture. The specimen source or the type to be given with the relevant clinical details and provisional diagnosis so that appropriate laboratory tests can be performed. Okay, and here if the sample is to be shared with the other sections, it should be mentioned on the sample. Coming to the samples like the skin scrapings and the hair should be plugged. It should not be cut with a scissor. It should be plugged, And the skin scrapings, I mean, even the collecting the nail samples, it should be properly cleaned first with the alcohol. Next, we need to collect these samples from the underneath. Like suppose if you're collecting the skin scrapings, better you take the scrapings from the fresh lesion, and better you scrape from the edges of the lesion, because those are the sites where the fungus can be yielded. So if you send a proper sample, will yield a good result. If you send a wrong sample, so the sample, even the patient is having a fungal infection, will be given as negative. And whatever the sample may be, it should be transported less than 2 hours to ensure the optimum recovery of the fungi. What are the don'ts in the fungal culture specimen collection? The scanty materials in the dry swabs and whatever the aerobic samples, like the surface samples, are not accepted for the fungal culture. And even the saline, which you keep for the biopsy tissues, which contains antibiotics, that is not suitable for the for keeping the tissue sample. The specimens that are unlabeled or improper, non-sterile, leaking containers are not to be accepted. And the tissue specimen to be sent in saline and should not be in a formalin. So even this blood culture can yield, in case of the candidiasis, can yield the positive results, depending upon the sets. Like the fungal, now it comes in the pyrexia of unknown origin among all these cases. So now in PO, how many sets you send? So the set means the number. It means the blood which is drawn from the one venipuncture site. So 2 to 4 sets over 24 hours can be sent in case of the pyrexia of unknown origin. So when you're suspecting cryptococcus infection, so better you further incubate the plates so that we can get the growth. So coming to the how we diagnose the fungal infection is what we take a sample, we just go with the microscopy. So in the microscopy, what all things we have, we can do the potassium hydroxide preparation, lactoferrin cotton blue preparation, and the other special stains which the pathologist will give you, like Manson Fontana stain. We have to look for the Gomori methamine silver staining and HNE staining, and also we do culture. So coming to the potassium hydroxide preparation, so about it ranges about 10 to 40% depending upon the sample type. For the routine sample, about 10 to 15% of the KOH we use, and for the other samples which we don't dissolve, like the hair, nail, and tissue, we use a 40% KOH, and specificity range about 30 to 40%. So this is a picture showing the hyphae from the positive nail sample. This is the hyphae, the KOH preparation. So these in this picture we can see the numerous arthroconidia within this is the hair. This is the hair shaft. We can see the numerous arthroconidia within the hair shaft. So this is the condition called as ectothrix infection. This is a positive sample at VDC. So in the microscopy, what are we seeing? We are seeing the sample type, and next we are seeing the type of the hyphae. So the hyphae may be of septate hyphae. It's called as this. These are the septations in the hyphae in the KOH preparation. Now these are the broad aseptate hyphae which are sparsely septate. So there are two broad type of the hyphae which we come across. So apart from this hyphae, we can also see a demeticious or the pheoid pigmented hyphae. This is a KOH preparation where we see a brown colored irregular hyphae will be seen in case of the pheohyphomycosis. So here we need to actually differentiate the hyaline and the pheoid fungus, and because the treatment also varies. Now how we identify, even we can go with the lactophenol cotton blue. This preparation is widely used. Here in this, all the four components, they are very important. Like the phenol acts as a disinfectant and kills the fungus. Lactic acid preserves the fungal morphology. Glycerol prevents the drying, and cotton blue will stain the outer wall of the fungus. And it's performing two ways, like standard teas and teas mount. Teas mount and a cellophane tape mount. So this is how we do a cellophane tape mount from the culture, where we take a tape and just touch the culture, put a drop of the LPCV, next paste that cellophane tape. So this is a view where we see and report the cases depending upon the morphology. So the stains are like Gomori methamine silver staining, where the fungus will be stained black. This is a Jimsa staining, where we can see the hyphae. So coming to slide culture, why we do a slide culture? If we are not like conformed with the actual morphology, what we see with the LPCV, you can further go with the slide culture where we can actually see the complete morphology of the fungi. Like, can you see a stolon here? And this is a gonadiophore bearing vesicle and the medullae and the phyllid and the series of the arrangement of the conidia. So in this slide culture, we can know the arrangement of the conidia, and we can even know whether it is uniciliate and biciliate to speciate the fungi. So, the choice of the culture media should contain an antibacterial agent and the antifungal agent. So, in our commercially available media will have the chloramphenicol, which is an antibacterial agent and antifungal agent, like cycloheximide, which is also called as actidium. So, all these fungal cultures should be stored at 25 to 30 degrees Celsius. And coming to the case of the dimorphic fungi, which grows both at 25 and 37 degrees Celsius. Coming to different types of the media in the SDA, this is the most commonly used media. Its pH range is about 5.6. Coming to the neutral SDA media, which is Ammon's modification, its pH is about 7.2. Next, we have other media like nutritional deficient media, which is used for the production of the chlamydospore. Next, other enriched media like brain heart infusion agar and blood agar can be used for the candidiasis, cryptococcus, and histoplasmosis. Next, coming to the selective growth of the cryptococcus, we can use an Iger seed agar and the bird seed agar. So this is a chrome agar, Canada chrome agar, which is used both as selective and differential media to speciate the Canada. So this is how we do a examination from the culture tubes. So we examine all this culture till 4 weeks. Better we see twice in a week these cultures, and finally the no growth of the report can be given when there is no actual growth. So if the growth is present, suppose if there is a uh, Canada-like growth, we usually perform gram stain for the yeast, followed by the Malditoff and YST by Ytec 2. And if there is a mold, you can go for the lactoferrin cotton wool preparation. And if for the speciation, we can go for the slide culture. So the types of fungi are what we are reporting. They may be under headings like yeast, yeast-like, and molds. Yeast are the true yeast, like Cryptococcus neoformans, which is pathogenic. Yeast-like are the Candida, which will have a pseudo hyphae. Molds like we can have the septate and the aseptate hyphae. Among the other than the mucorales, all the fungi will come under the septate group, where it may be an hyaline, which is a non-pigmented hyphae, or whether it may be pigmented, which is called as a phaeohyphomycosis. So either it may be a hyalohyphomycosis or phaeohyphomycosis. Coming to the different types of fungal infections, it ranges from about superficial mycosis, subcutaneous, systemic mycosis, and opportunistic mycosis. In case of the superficial mycosis, so this is an example of the pityriasis versicolor caused by the Malassezia furor, where we can see the tiny white patches over the cheek and from on the nape of the neck also. On the KOH filtration, we can see both yeast and the hyphal forms, which is called as spaghetti and meatball appearance. So the other most common infections in the superficial infections are called as dermatophytosis. In this, we will be having the three genera, that is Trichophyton, Epidermophyton, and Microspora species. Coming to the Trichophyton species, how we can differentiate Trichophyton species? So it is with the abundance of the microconidia, and microconidia will be rare. So this is the Trichophyton rubrum, this is metacrophytes, and this is tonsurans. So rubrum will have the colony red, and here we'll be having the tear-shaped microconidia which will be abundant and bird on tree appearance, and the pencil-shaped macroconidia will be there. Here we'll be having the in the Trichophyta and Mentagrophytes, the clavet-shaped macroconidia and the spherical microconidia which are abundant, and we'll also be having the spiral hyphae which I'll show you in the next slides. In the Trichophyta and Tonsurans, we'll be having again a tear-shaped thick-walled macroconidia, and the microconidia will be rare. And here the hyphal wall will be in a tortuous form. That's why it's called as Trigophyton tonsinus. This is an epidermophyton where we see an abundant macroconidia which will be in a form of clusters, and there will be a club shape. Here the septations will be around 2 to 6 or 4 to 6 ranges. But the here coming to the microsporum species, the septations will be more, and here the macroconidia will be a spindle shape. In the Microsporum species will be seen a rare Microconidia. Okay. So this is a Microsporum canis. So this is a case where we see a condition. So all the dermatophytosis infection called as either a tinea infection or the ringworm infections. So here the condition is called as a tinea corporis. Here we see a concentric circles, itchy concentric circles over the trunk. So affecting the body is called as tinea corporis. Culture, the cultural morphology of the trichophyte and mentogrophytes are like powdery in appearance, white to tan powdery in appearance. And here, when we make a LPCB mount, where we can see a morphology of the trichophyte on mentogrophytes with the spiral hyphae having chlamydospores and the spherical shaped microconidia and the clavet shaped macroconidia. So this is a one more case of the tinea corporis. This is the club-shaped chlamydospores. Coming to tinea capitis, showing the pathogen that is the Microsporum species. Coming to subcutaneous mycosis, where we come across routinely this subcutaneous mycosis. The subcutaneous mycosis usually follows the traumatic inoculation of the fungi into the skin. So coming to one of the conditions called as eumycetoma. Eumycetoma having a clinical triad of the swelling called as tumefaction with the multiple sinus tract and having the grains. So the here collection of grains is very important, not in the skin biopsy, but the grains will yield the positive result, and we can diagnose what actually the fungus is. So whatever the fungus is collected, you should observe the color of the color of the granules, like because we have to differentiate between the eumycetoma and the actinomycetoma. Eumycetoma means which is caused by the fungi, through fungi like example Madrilla species. So where the actually the color of the granule will be black. So mostly the actinomycetoma caused by the bacteria will be ranges from about yellow to white granules. So here we see an example of the eumycetoma caused by the Scedosporium apiospermum, which is a phaeoid fungi. So here is a foot, here is a grain observed, here is a culture, and here is the LPCB mount of the Scedosporium apiospermum, where we see the separate hyphae with the conidiophore bearing a single conidia. So this is actually a characteristic of the Scedosporium apiospermum. So this is the eumycetoma caused by the bipolaris. So next we go with the condition called as pheohyphomycosis. This pheohyphomycosis can range with the skin infection, subcutaneous till the systemic infection. And here we present a case. Here we see a case of the caused by the Cladophillophora bantiana, which is causing a systemic infection, brain abscess condition. Usually we isolate this from the brain abscess. Here is a pH preparation of this fungi, which is having the brown irregular hyphal structures. And here is the histopathological examination of this fungi. And this is the color of the colony. Don't take it as a contaminant because it's a pathogen here, which is an olive green in color, and here is the LPCB of that fungi, having the long ellipsoidal chain of conidia without properly differentiated conidiophores. Here we don't see a conidiophore. Directly we see a conidia on itself a vegetative structure. Coming to opportunistic mycosis, ranges from about candidiasis, cryptococcosis, zygomycosis, aspergillosis, penicilliosis, pneumocystosis, and fusariosis. Coming to first one, that is a candidiasis. So we can yield the candida with our routine automated blood culture system. So when the signal comes positive, we can make a directly gram stain. The color of the colonies will be the creamy pasty colonies, and the gram stain will show the gram positive budding cells. And we can also further test with the germ tube testing with the albicans and the non-albican species, where the germ tube is positive for the albicans. And identification can be done by the Malidov and the Vitek to AST system. We can get the AST with the 6 drugs. Cryptococcosis we usually see in HIV positive patients. We can even confirm this disease with the cryptococcal latex agglutination test. And here the CSF will have the positive India showing the showing the capsule around the Canada. Coming to aspergillosis, uh, this has been isolated from an oral swab, where we can see the yellow to green colored powdery colonies will be seen, and LPCB mount showing the community of 4 bearing a cycle which is covered by the cornea about two-thirds. Coming to mucormycosis, the here the predisposing factors will be the COVID patients and the diabetic patients. Here the KOH is showing the aseptic ribbon-shaped hyphae, and here the color of the colony will be the salt and pepper appearance. Here the fluffy colonies will be formed, and here is the LPCB mount of this fungi showing the broad. Here's, can you see here? The septations will be broad septate bearing the sporangia, sporangiophore, and the sporangiospores. So these are the other few fungal species identified in our lab. This is a fusarium having a sickle-shaped microconidea. This is Aspergillus fumigatus, Curvilinia lunata, and the Rhizopus species. The overall treatment of the fungi, well, the groups are like we are having amphotericin B, which can be used for all the invasive fungal infections. Histidine is used for the topical fungal infections. Coming to the echinocandins like caspofungin and metafungin can be used for the systemic infections caused by the Candida and Aspergillus. Next, the mesofalvin can be used for the again dermatophyte infection. Coming to triazoles like fluconazole can be used for the cryptococcus and the Candida, except the Cruzi and glabrata where they are intrinsically resistant to the fluconazole. Itraconazole can be given in case of the sporotrichs from blastomycosis, and even we can give to the cryptococcus patients also Candida and trichosporon infections. Voriconazole can be given to all invasive fungal diseases except mucormycosis. Posaconazole and isavuconazole can be given to all invasive fungal diseases including mucormycosis. Again, terbinafine can be used for the topical use. And thanking you. So the overall, this topic says it is a very time-consuming procedure, but it is an diagnose. We can give a diagnosis to the patient, and patient can be treated and can be fine if it is cutaneous, like for example a cutaneous mucormycosis. This condition can be treated if the if we can directly inform to the doctor that positive that the tissue is positive, and immediately there should be a proper debridement. So the proper debridement, even after debridement the sample is sent. If that again if the tissue is like negative after debridement, so the we can stop with that, and patient need not take the treatment of the amphotericin B. Right, thank you.
Yeah, thank you, Dr. Bushra, for this elaborative and comprehensive overview of fungal infections. One has to keep a very keen eye of suspicion regarding fungal infections because of increasing antibiotic usage across hospitals and clinics likewise, and because also the institution or starting of the treatment is also equally important, because faster institution of therapy will lead to better outcomes in case of fungal infections. Thank you everybody for joining our session.